addiction group with me. We've got Dr. Bishevitz, Dr. Connor, and Dr. Gorodetsky with me, as well as several students, residents. We have some guest presenters today. Michael Keenan from the SUNY Upstate Emergency Medicine Residency Program, as well as Henry Swoboda will be presenting some additional cases. So I want to thank them for sending cases. If you have a question or comment, please raise your hand and Tricia will be unmuting. You can also communicate with the chat. I think I'm registered under Ken Connor, so it won't be coming under my name. So you have to address it, I think, to Ken or to Tricia, and we'll communicate the questions as well. So, Mike, are you unmuted? The SUNY Upstate group?
There we go. Can you hear me now?
Yes, I can. So first case, just let me know when to advance and take it away.
Sounds great. Thanks. Hi, guys. I'm Mike Keenan. I'm actually a resident at University of Buffalo, but this case I saw as a visiting resident in Syracuse, so we can jump right in. So this is a 19-year-old male with a history of substance abuse that came to the ED with anxiety, palpitations, and insomnia after abrupt stopping of his phenibut 2 days prior. He had actually used phenibut in the past. About a year ago, he was admitted to the ICU for withdrawal. That was significant with delirium, agitation, and rhabdo, but he started it back up 2 months ago just to try and deal with his anxiety and insomnia, but he steadily increased his dose to 5 grams daily. But he felt that his dose was escalating too much, and so he stopped it cold turkey 2 days prior to coming in. When he presented, he was tachycardic in the 130s. Next slide. And so I just want to stop there for a minute and just see what everyone's thoughts are. What is phenibut? How would you manage this patient?
Great, thank you, Mike. Has anyone heard of phenibut or taken care of patients with use, dependence, or withdrawal?
No takers?
Dr. Bishevitz, have you heard of phenibut?
I've heard of it in this conference. I've not had the occasion to see it yet.
What about, I can't see the attendee list, but if anyone has a comment, certainly there's people on the line that have seen or heard of phenibut. Let me ask Henry, I know that you're on, have you heard of phenibut or taken care of anyone with use?
Yeah, I've seen a couple of patients with phenibut. My understanding is that it's a GABA B sort of ergic drug and agonist there, and so that's rapidly addictive, at least as it's reported in the literature, that people become dependent on it and have withdrawal symptoms fairly rapidly after they start using it. My experience has been that it presents with maybe a little bit of additional neuropsychiatric overlay than your typical alcohol or sedative hypnotic withdrawal, but can be managed similarly. May want to add on some baclofen, given its GABA B potential, and you could kind of titrate it up and then taper them off if that was how you choose to approach it, or with any other sedative withdrawal, consideration of phenobarb is always an option as well.
Yeah, awesome.
Thank you.
Awesome.
Now, from what I understand, this is available in some other countries, or has been. It was used as a sleep aid in cosmonauts or something like that. And we've had a couple of cases in Rochester. I've not had somebody that has had dependence and withdrawal, but usually when I see phenibut, it's mixed in with some designer benzodiazepines. The individual has a lot of knowledge of alternative highs, novel psychoactives, and it's often not, from my experience, the only substance that someone's using. You know, it's interesting in the description that I heard from Henry and yourself as well. It seems similar to GHB abuse and dependence, certainly, potentially.
Yeah, definitely. If you go to the next slide, if you don't mind.
So,
yeah,
good.
pretty much hit all the nails. So it's structurally very similar to baclofen. Like you said, it's a GABA B agonist. It was actually originally developed in Russia in the 1960s and was used for things like anxiety and insomnia. But you can buy it legally online in several vitamin stores, and it's advertised as a alternative for anxiety, insomnia. People use it as I'm probably saying this wrong, the nootropic, the cognitive enhancing drugs. And so that's what you see most people using it currently. The conversion that some people have reported is that 1 gram of phenibut is approximately equivalent in dose to 10 milligrams of baclofen. That's what's been described in some of the case reports. Next slide.
It's interesting. I just wanted to comment. I'm looking at the structure, how similar it is to both gabapentin and baclofen. So this would probably be classified as a gabapentinoid structurally and mechanistically, which gabapentin, baclofen, and pregabalin are gabapentinoids.
So, like the other gentleman said, phenibut withdrawal is managed similar to benzos, baclofen, and alcohol withdrawal, and you'll see similar presentations. You'll have agitation, irritability, disorientation, inability to sleep. Next slide. And it's something that's been described in the literature, not a ton. It was a paper that took a look at a bunch of different reports of phenibut withdrawal and dependence, but the 4 that are highlighted there were reports that used baclofen in a taper format to treat the phenibut withdrawal. Next slide. And what's been described is a taper that's varied anywhere from the shortest one that I could find was 6 days, and then the longest one is what's described here is 24 weeks. And in this case, this 24-week case, they actually had them start on the baclofen and go up on the baclofen and down on the phenibut, and then titrated the baclofen down. Other cases have them go off of the phenibut and then just start at a baclofen dose that's approximately equivalent, and then titrate down from there. And if you go to the next slide, that's what we did. So the patient was taking approximately 5 grams of phenibut a day, and using that case report that described an equivalence of about 10 milligrams for every gram of baclofen, we started titrating up the baclofen to what ended up being 45 milligrams, where he had notable symptom relief. He was in the hospital for about 2 days, which was significantly shorter than the year prior when he was admitted to the ICU. And when he went home, we titrated him off, going down by 5 milligrams of baclofen every 4 days. And the taper was designed to last about 4 weeks. We saw him, if you go to the next slide there, we saw him 2 weeks after discharge, and he was following the regimen as we had described to him. He had not required any additional dosing. We did provide some additional baclofen that we described that he could take for breakthrough every 8 hours if needed, but he didn't require any of that. He had improved sleep and anxiety, and he felt that this was going much better than the last time that he had stopped the phenibut. At our follow-up appointment, he was arranging additional follow-up substance abuse support services. You can see his vital signs there. He is a little tacky, but he is baseline very, very anxious, and this is kind of how he always seems to be. I don't think this is related to the phenibut withdrawal at all. But compared to when he came in, when he was in the 130s, 140s, significantly better, and he felt significantly better. So it was cool to watch this taper work. The exact duration of the taper, I think, isn't really well described right now. Like I said, the ranges that you see in the literature is anywhere from 6 days to 24 weeks. It's a huge range. We're on the shorter end. The other one that I saw written up was 9 weeks. I don't think this really tuned into exactly what the optimal duration is. It obviously has a lot of the patient variation that would go into it, and so that's the case.
Thank you. That's a really interesting case and protocol. I'm wondering what other comments, questions. Maybe is Dr. Marafa with you as well, Mike?
I'm actually calling in from Buffalo, so
Okay.
she's on the other line.
Maybe we can get some comments from the SUNY group as well to see, some. I know that there's been some other cases we've discussed. It seems like you've had more exposures to phenibut.
Tim, can you hear me?
Yes.
Okay, this is Mike. Yeah, I was with Mike Keenan when we saw this guy, and I guess one of the other things I thought was really impressive with when we started him on, sort of an escalating dose of baclofen that first day, is he was really, really anxious, and we did have PRN benzodiazepines available to him as well, and it turned out he didn't require a single dose of a benzodiazepine. This was basically all baclofen that treated him, and I think for the first couple nights, in the middle of the night, he got a dose of hydroxyzine to help him with sleep, but that was really the only other medication that this young guy needed.
That's really interesting that, you're able to dose the baclofen so effectively. In thinking this through, I've seen reference to the baclofen tapers, and my go-to usually for this, in fact, we've got a couple people in the hospital right now that have had overdoses with mixtures of benzodiazepines, baclofen, gabapentin. It seems to be kind of a common theme lately, and we're using phenobarbital, our standard kind of 3-day protocol after they're out of withdrawal. We're recommending that, and one of them's in process of getting this done now. So it's not phenibut, but similar medications, and I've seen phenobarbital very effective in terms of cross tolerance, and we don't have to use the same duration, as the baclofen regimens, potentially as this, but I haven't tried that in a phenibut dependence and withdrawal. Henry, I know you have your hand up. You have comments, questions?
Yeah, I was just curious about the kind of follow-up plan for this guy. I mean, I think probably because I'm doing a lot of Suboxone, I end up doing a lot of kind of weekly visits for these people. Were you guys prescribing him just, the whole duration of the taper of the baclofen, or were you having him follow up for reassessments and repeat prescriptions, or how did you coordinate his follow-up for this kind of prolonged detox?
Yeah, our original plan was to have the inpatient service just prescribe the initial week, and then have him, when he followed up with our original scheduled appointment, we were going to prescribe the rest of it. There was a miscommunication. Actually, the inpatient team prescribed the entire course, so he actually had the entire prescription from the hospital discharge. But the original plan was to have him follow up the first week, and then we would prescribe it further.
There's a question from the Iowa Poison Center that joined just a little bit late. How much phenibut was he using daily? What again was the regimen he was using?
He had increased to 5 grams daily. The exact regimen, as far as like how he was spacing it out, I'm not sure, but total of 5 grams daily. I
have a question. So phenibut is a much less potent GABA B agonist. Are there any other receptors, areas where it has activity?
From what I saw, I only saw it described as GABA B. I'm not sure if Dr. Hodgman has any other thoughts on that, but I only saw a reference to GABA B.
No, I don't have any other comment on that.
Well, thank you for presenting, Mike. That's really interesting. I think, this is probably going to continue as more and more people find out about it. And, gabapentin potentially is restricted. Several of the states, in several states in the United States have it it's not controlled, but it's included in the prescription monitoring programs. And I think, in particular, when patients have opioid use disorder, it's now, instead of, being random, prescribed very commonly, it's being restricted a little bit more. People have it on their radar, so it'll be interesting to see if there's an unintended fallout with phenibut or even other analogs of GABA.
Yeah, it's very interesting when you go on the websites that sell this stuff. The comments from the users are all they all praise this as this very safe alternative. I don't think they realize the danger. So it's interesting to see. But thank you for having me on to talk about this case.
Yeah, very nice job. Thanks. All right, some references, and we've got the second case is one that I'll be presenting, and then Henry's up after that. So this is a gentleman who I took care of recently, 38-year-old with alcohol dependence, has had recurrent admissions for the treatment of alcohol withdrawal. He's drinking about 3/4 of a liter to a liter of vodka a day, and he'd had intermittent off and on sobriety. He would get a month or two sober and then relapse with alcohol and get another period of time sober and relapse. He presents to the emergency department with chest pain and tremor, tachycardia. He's sweaty, he's anxious. He says he was trying to detox at home, but he was worried he was going to have a seizure, and then he had this chest pain. He is supposed to be taking some medications. They didn't have a complete list initially. One of them was amlodipine, and he hadn't been taking that, but thought, well, maybe I should take one of these for the chest pain. It didn't help, and so he came into the emergency department. His past history is the alcohol dependence with periods of sobriety. He's had some recurrent episodes of withdrawal, relapse. The last year has been these on and off episodes of drinking. Usually it lasts about 3 to 4 weeks, heavy use, and then about a month sober. He lives alone, smokes tobacco. He has a history of prescription opioid abuse in the past. After a car accident and injuries, he was able to stay away from prescription opioids, he said, after a period of struggling with that. In the emergency department, he's given phenobarbital, and his evaluation of the chest pain is unremarkable in terms of cardiac or pulmonary. The troponins are negative, EKG shows sinus tachycardia. His labs are fine except for a little bit of hypokalemia and a slight anion gap with a bicarbonate of 18. We don't have an alcohol level in this admission, but a few months prior he had an ED visit with an alcohol level of 439, and he was awake and going into withdrawal then, so he's got pretty severe alcohol dependence. He's given phenobarbital in the emergency department. His heart rate's in the 130s, and over the first 6 hours he's given fluids with dextrose after thiamine, some electrolyte replacement, and 520 milligrams additionally of phenobarbital, and his symptoms improve moderately. He's put on a withdrawal protocol as he's admitted using phenobarbital 130 to 260 every 4 hours for mild to moderate withdrawal symptoms, and given some adjunctive clonidine. The clonidine helps as well. He does well overnight, and the following morning we see him, he feels a little bit better, but he's not quite at his baseline. We actually call the team and give him additional dose of phenobarbital at the bedside. The residents are able to administer that, and he feels a lot better after that. And he also admits to using kratom 3 times a day since stopping prescription opioids, and he still has some restlessness, some anxiety. He doesn't think it's the alcohol withdrawal. He wonders if it's from the kratom. He's not sure if these residual symptoms may be due to not having kratom. So let me see. So what is kratom? Can withdrawal develop from cessation after regular use? How would you treat withdrawal if it can develop? Anybody have any comments or questions regarding this case? Maybe Dr. Bishevitz, you want to weigh in?
So kratom is a plant, and the active substance in there is mitragynine, which is very, it goes to the mu receptor, activates the mu receptor, and people can indeed become very accustomed to kratom and can develop withdrawal after cessation. It's usually milder than with the full mu agonist opioids that we're used to. I've seen some case reports of treating kratom users with Suboxone, but I would imagine you probably could try to do it without Suboxone and use clonidine, at least at first. See if they really needed Suboxone or not.
Now, have you treated kratom withdrawal with Suboxone, or?
No, I've just seen case reports of this.
Does anybody have other comments or questions? Become very popular in our area. There's in fact a store that's the Kratom store, I think it's literally called, on Monroe Avenue in Rochester, and the owner drives around in a van that's Kratom, safe and effective, and is really touts the benefits of kratom for not just coming off of opiates, but pain, depression, anxiety. Listening to him, I think he's kind of making medical statements about its benefits. I think it'd be interesting to see if, somebody with in the right authority heard some of the statements. But it's very popular. Other comments? Dr. Dye mentioned she had a patient in her clinic on Suboxone for kratom. So Leslie Dye is taking care of patients with dependence to kratom and use Suboxone. Can you comment on the dose?
Can you hear me, Tim?
Yes.
It wasn't mine. It was a colleague's. I had trouble spelling colleague, so it took me a while to type it in. No, it wasn't mine, so I'm not sure what the dose was.
Hi, this is Ingrid. Can you hear me?
Yes, go ahead.
Yeah. I've had a couple of patients who we were having difficulty getting them stabilized on Suboxone. The dose seemed to be escalating, and in discussing with them, one in particular I remember was doing kratom on the side, so without appreciating that this was almost as if they were continuing to use opiates, and so we kept trying to chase the dose of Suboxone. So once he stopped the kratom use, we were able to get him on a reasonable dose of Suboxone. So I always ask my patients when they first present if they're using kratom or loperamide or ibogaine, certainly in our environment, I only hear very rarely if they use kratom. Some of the people who have used kratom in the past do talk about how terrible it tastes.
Huh.
Yeah, I've heard that before. In fact, I've heard, all sorts of different concoctions, heat it up, mix it with lemon juice, plug the nose as you just swig it down, just get it down because it's nothing that'll make it taste better. So people seem to have their favorite recipes for the kratom, depending. And then there's also capsules. People have capsules, I think, to probably allay the taste, and crushed leaf. Dr. Malko, have you seen anyone with kratom during the fellowship?
We had one patient who presented to the emergency department with kratom withdrawal. It was very mild. We were able to control his symptoms with supportive care. But he certainly bought it from a similar store that you're referring to locally, and thought it was a safe alternative. And I think his general understanding of it was that it wasn't a concerning use, and we worked with him on that.
We've had I think I've had equal number of patients frustrated with buprenorphine and the whole addiction treatment complex, and come off of opiate agonist therapy and order kratom online and swear by it, that it's miracle, wonderful. There's people I've seen that have chronic pain that have come off opiates and swear by it as well. They tend to be very vocal. And then I've also had patients that can't afford it anymore, can't stop, have craving, and want to go back on buprenorphine and thinks it's miserable. We've had a couple of cases of adulterated kratom over the years. One recently had a phenethylamine confirmed as added to the kratom when somebody bought a different product. They couldn't get it online for a period of time. And then I've had a couple of patients that have come in with jaundice and bump in transaminases and bilirubin, and they're using kratom, and then we're trying to determine, is this from kratom, is this from other reasons for the hepatitis, and it's only been a handful. So who else? Anybody else have any questions or comments on stories about kratom?
It also came up this is Jade, an interesting setting with a recent consult for a patient with active IV drug use. She had abscess cellulitis in her hand, and we were trying to reconnect her to outpatient Suboxone therapy and chemical dependency treatment. And she kind of was very honest that she didn't enjoy being in a traditional chemical dependency treatment group. She struggled with that a lot, had a lot of domestic violence issues and psychiatric trauma. And she said to us, if this doesn't work for me, I'm just going to go back to using my Kratom because I can stay out of withdrawal. I'm not using IV drugs. And that was kind of her backup plan. So recognizing that it can be a limitation, having access to something like this might create a barrier in your overall kind of trying to discuss with patients about what their options are instead of continuing to use IV heroin.
Yeah. And I don't, I'm worried about that whether or not it's disclosed or not, and I haven't had anybody with precipitated withdrawal after starting buprenorphine that had undisclosed Kratom use, but I imagine, it could happen if they came in and they hadn't really thought it through. I've heard from some patients that the withdrawal is not perfectly treated with buprenorphine. You're taking care of the mu agonist effects, but Kratom also has a stimulant effect at low dose from the methadronine, and it's a very complex chemical with a lot of interesting pharmacology. So there's not a perfect match with buprenorphine or the other opioid agonists. I think, adjunctive clonidine. And so, but in this case, we had started buprenorphine, a small dose, a 2 milligram sublingual once, and he was put on a 2/0.5 of the buprenorphine naloxone films 3 times a day and reassessed. And, I'm looking for sedation since he's gotten phenobarbital. I don't know the equivalence, between this and the Kratom, but he tolerated this just fine. Most of the patients that we've transitioned onto buprenorphine from Kratom do fine at the lower doses, at the 2 milligrams twice a day or 3 times a day. It doesn't seem like I've had to escalate the doses in many of them, unless there's a long history of other opioid use and high levels of dependence, then usually they needed to get to bigger doses. He was given some additional phenobarbital on day 2, did really well after that in the buprenorphine, and he was linked to follow-up after 2 more days of monitoring in the hospital. And at follow-up, he was taking the buprenorphine naloxone, had not returned to Kratom, looked better, and denied alcohol use, although the labs were pending at the time of follow-up, ethylglucuronide and the other standard labs to confirm buprenorphine. But he looked a lot better, came to the appointment, seemed appreciative, and was attending groups and counseling, and seemed to be doing much better than he had at home using the alcohol and Kratom. Any other questions? Anyone from Arizona want to weigh in, comment, question?
Hi, this is Henry. Oh.
Yep, go ahead.
It's Henry here. I just had a question. My reading of the handful of case reports out there of Kratom and liver disease is, as they are in these sorts of situations, is that they're messy, and I've never been able to form a firm opinion on whether I think it's really associated with liver injury or not. I don't know. What are your thoughts on that? Do you think it really is associated with some degree of liver injury, or it's still just kind of a messy situation?
Oh no, I definitely think it's a messy situation. It's really not clear. Each of the patients I've seen have had, other issues, and it's only a handful of cases over the years. And I think, is it associated with it, cause it, or just found in somebody now that has, bumped transaminases and elevated, the pattern that I've seen, reported is it's cholestatic jaundice, so not just pure hepatocellular. And I'd still advise stopping the Kratom and, switching to buprenorphine. Sometimes I think most of them have been in the ED presentation and recommended follow-up and have not followed up. But, yes, I think it is messy as well. I bring up in counseling, too, the cases of adulteration and, treated as a supplement. So, what you see, what you order is not necessarily going to be, what you're expecting potentially. So, I think there's, opportunity for problems because of the, the lack of regulation, certainly. Well, if we don't have any other comments or questions, we've got some cases that you've presented, Henry.
Sure thing. So, as you may have noticed, my voice is going on me a little bit here. So, if you're unable to understand me, just speak up, and maybe we'll have one of my colleagues here start presenting the cases in my stead. But I'll try and make them through here. So the couple cases, I'm talking about acute rehab. I'm talking about physical rehab here, and how that can kind of have an interplay here. So our first patient, I've got two cases. Are these the last two cases, Tim, or should I hurry through?
No, these are the last two. I took out the precipitated withdrawal cases that we've
Okay.
got. We'll focus on that this next session, so you've got plenty of time.
Got some time. All right. So the first one's a 50-year-old man. He had like a fall, and he was okay for a while. Had some like neuropathic symptoms, but weren't too bad. But then had some progressive weakness. And so presented to the hospital. He had a history of opioid use disorder, was still using heroin a couple times a day on top of methadone. He had actually been doing okay back when he was on 55 milligrams of methadone, but it was his desire to get off of it. He didn't like how it made him feel. He really did feel like it was substituting in a way that he didn't like. So he wanted off, but then he picked heroin back up when he was trying to get off of it. So he had this traumatic cervical myelopathy, and they had a planned C3 to C6 laminoplasty. So I guess my next slide, I guess, is what is your approach? So he wants off methadone, and he had never heard of Suboxone before. He wanted to get on Suboxone. He said, "Yeah, I hated going every day. I don't like the way it made me feel. If you're telling me Suboxone, you feel a little different, and you don't have to go every day. Then I want on that." So he's got a couple of days. He's in the hospital. He's being worked up. He's getting MRIs and stuff. What were your guys' approach be in this kind of acute preoperative setting? Does anybody have any thoughts on that?
So anyone can raise their hand and comment. This is a preoperative management of patient on methadone. This is through an opiate treatment program, obviously, Henry?
Yeah, that's where he gets his methadone, correct.
So, Gloria, if this is your patient, what would you recommend?
Well, I would recommend that he just stay on methadone for, to get past the surgery, because it's worked for him at least a little bit, rather than try something entirely new, do the transition in the hospital, because you might waste some time in the hospital doing that. I don't know. It just always seems to me that it's more efficient to do one thing at a time. But I could see where he'd want to have one-stop shopping and do that in the hospital.
That's good. We have a patient, kind of similar, when I asked one of our residents that's here, what have we done? So patient on methadone comes in, acute pain, maybe as a procedure. What have we done for methadone? Tim?
We switched him over to buprenorphine.
So when we had a gentleman come in on 100 milligrams of methadone, and he's got an abscess in his hand, cellulitis, and...
Yeah. So
Jen, yep.
It was 90 milligrams a day confirmed with outpatient program, so first split to 30 TID for same total daily dose for opioid maintenance therapy, but split for better analgesic effect. And then this is someone who is well known to the toxicology service. I'm a resident rotator, so I don't know him so well, but I know behaviors in the hospital and drug use in hospital has been an issue. So he needed BID packing changes for this hand infection, so did an additional 15 of oxy twice a day as needed, and it was we set strict limits with him, so it would be a pre-medication an hour prior to dressing change, where you'd anticipate the most pain, with discussed limit setting on behavior. So, if he left the unit and came back and then had a packing change, couldn't ask for the PRN after that, and if he got the oxy, he would have to stay until the dressing change was done and things like that.
Yeah, that's good. So splitting the dose more frequently, usually I think it's optimal to split up to 3 times a day. You're going to get the same effect on dependence, craving, withdrawal, but you'll have better analgesic effect. And, if there's a period of time he couldn't take oral, was intubated, you could switch to IV, and you would do 50% of the oral dose. And if we're going to add full agonists on top, we usually do 2 to 3 times the standard dose of whatever full agonist. So it wouldn't give this gentleman 5 milligrams of oxycodone or hydrocodone. I'd probably go 10 or 15 milligrams of hydrocodone or oxycodone, and depending on what the acute pain was. And then if the patient's on higher doses of full agonists and really, struggling during the hospital stay, you could communicate with the opiate treatment program. Are you able to go up on the methadone with their, approval and understanding, and then you could increase based on the standard outpatient recommendations for increasing methadone, which is 5 milligrams every 2 to 3 days potentially.
Yep, every 2.
Every 2 days. So I don't know if I would jump at buprenorphine right before. I think that's a lot of stuff during this hospital stay, but he's got some good options, splitting the methadone and going from there. Any other thoughts or comments? Thank you, Jen. That was good.
Well,
advance.
Yeah, go ahead and advance. So I think that was a great discussion there, and we tended to agree with that, with saying, listen, you're on methadone, you're not withdrawing, you got surgery coming up that we want to get done as soon as possible, given your neurologic issues. Let's keep you on the methadone, and he actually did really well with that. I mean, we actually didn't even end up having to split it. For us, it just kind of helps us, I think, convince our surgical colleagues that the methadone is not for pain, so we're not messing around with it. They gave him some morphine or some Dilaudid for a couple of days in the immediate post-op setting, and then got him down onto Norco 10s, Q6 PRN. That was pretty well controlling his pain at that time. And then we were fortunate enough to find out that he's going to be going to the acute rehab hospital that's attached to our hospital for the next 2 weeks. So we know we have his pain well controlled on the regimen we have listed there. He's going to the rehab hospital where their ability to monitor him might be a little less. And he does have some requirement now to be, engaged in therapy. That's the whole reason he's going to the rehab hospital. But we have a 2-week window to play with. Any other thoughts on how about now? Now we got some more time. He's an inpatient. He's in a controlled environment, whereas in the past when he tapered down his methadone, he immediately went from 55 to 40 and started using again. So I was worried about tapering him in the outpatient setting if that was really his goal. So what would you guys do with him at this point?
Well, I've got some thoughts. Anyone else? Ingrid, are you still with us? Yep.
Yes, I am. I guess if he is in the hospital and still wants to needs to be aware of the Suboxone because he didn't know very much about it, that would be an ideal time to taper him off the methadone while you're slowly increasing, while you're concomitantly increasing the buprenorphine, starting really low. So almost like doing a microdosing, but you would be doing it. So I wouldn't take him off the methadone before starting him on buprenorphine. I would do both simultaneously, decreasing one and increasing the other.
Yeah, that's interesting. I've not had problems with the lower doses of methadone just going, 24, 26 hours, 28 hours after. If he's on 50 milligrams, if it's much higher than that, it's usually really hard for patients I've seen to taper slowly, and then keeping him in the hospital long, it's hard to justify that. I mean, I guess you could try and taper this guy and see how he did over the first part of the 2 weeks, but I might take his methadone dose in the morning, and then 26, 28 hours later, just start a small dose of buprenorphine, like 1, 2 hours later, 2, 2 hours later, 4, just kind of slowly titrating up. But I wouldn't continue the methadone as I'm doing that. I would just get him onto buprenorphine. And usually it's about a day or so of kind of, I'd feel a little restless, but patients typically get on it, tolerate that. In fact, we just did a similar case. Somebody was on split dose of methadone, 25 and 20, if I recall. Gentleman had quadriplegia, and we started right after 24 hours after, actually I think a little less. The guy, he got in a little hour early, and he felt a little restless with the first dose at 2 milligrams, but got some clonidine, and then took a dose later that day, and kind of hemmed and hawed, but it was more about, I think he was hoping that he could follow up outpatient, just keep getting methadone and other opioids prescribed, and more hesitant about the treatment program aspect of buprenorphine rather than that buprenorphine was really that different. There's much more to this case. The guy had been buying some pressed pills that had fentanyl and diazepam, so it was not just pain, and switched him to buprenorphine. But the transition went well. So I don't know if I do a microinduction or something like this. I think that gets a little overly complex, but maybe not.
I think my only reason for suggesting that my only reason for suggesting it really was the information that was provided initially, that he didn't do very well when he decreased his methadone quickly, and ended up using. And if he's in a inpatient rehab, is he able to go out? Would he end up getting heroin on the side anyways? So part of it may be psychological for him to say, look, we're going to decrease this slowly, increase this other drug slowly. We're going to not make you uncomfortable. And so there may be more of a supertentorial component to the approach that I was suggesting. That's
great. Thank you. Someone from UC Davis? A question?
Yeah, Dan Colby here at UC Davis. We've had some patients requesting to be switched from methadone and buprenorphine as well. We've had a little trouble with them, especially patients on methadone over 30 milligrams a day. We try to be aggressive with them because they definitely wanted it and preferred it, and we did share decision making with them. But we definitely had some precipitated withdrawals in our attempts, even 3 days after stopping methadone. So it definitely is complicated and challenging. So for this patient, I agree we don't want them to be uncomfortable, and they're more likely to go use illicit opioids if they are uncomfortable when withdrawing. At the same time, the methadone, I think, poses a problem. So other opioids, especially if this patient's under care still, probably makes sense. And then some people have had a lot of success with buprenorphine patches in these patients, and are able to bridge a little bit more elegantly than with the sublingual buprenorphine.
Those are good comments. Thank you.
Yeah, I think
B-Trans. Yeah. We don't have the Butrans patch on formulary. We've been able to get it for a couple of patients that when they come in, we continue it either with their supply or through a special exemption with the pharmacy. But it's been hard. But I've recently thought that it would be a much better opioid than buprenorphine, someone that had more exaggerated effects, not for transition. But good thoughts. Thank you. Sorry, Henry.
No, that's great. I think this has been an excellent discussion. We can move on to the next slide. And, so we were concerned of putting him into some degree of withdrawal for like 3 days. Our experience talking with our PM&R colleagues is like they get this duration of inpatient physical rehab approved, and that's how long they have, and you don't get a day more, and they got goals, and they have their therapy they have to do. So we were trying not to interfere with that or exacerbate his pain too much in that period of time. So we didn't want to cause precipitated withdrawal or have him have a couple of days where he was really under the weather and unable to participate. So we actually had some room to go up on his non-opioids, so we did that. Continued his PRN, Norcos, and we did kind of a slow taper on his methadone, with kind of the idea that we could at any time choose to just kind of rip the Band-Aid off, stop it, and do an induction after that. Hopefully when he already would have been on a lower dose, letting us do it a little more quickly. But if he tolerated it well, that we would then, towards the lower end, start to do this cross taper, since we had those 2 weeks to work with. So our plan for the cross taper was really just to hold his morning Norco, so he wouldn't take a Norco right before getting a Suboxone, and then he would get the Suboxone before his methadone. So if you go to the next slide. That's what we did. We gave him, like I said, those adjunctive meds to try and help with his pain, despite the tapering doses. And we tapered him down 5 per day. And then when we got him down onto 10, we started giving him just 1 milligram in the morning, 2 hours before his methadone. And then when he got down to 5 the next day, we gave him 1 milligram. And then the following day, he got 1 milligram twice a day. And he actually then, so this was our plan that I've written out there, but we added on him. He got 1 milligram BID scheduled on his first day without methadone, but he got 1 milligram every time, those Q6 hours, because he was starting to have some pain and withdrawal with all of that. And so he ended up tolerating 6 milligrams on his first day without it. So we actually increased him fairly rapidly up to that 2 milligrams QID, and got him on that with minimal withdrawal. He tolerated the methadone taper very well, and the cross taper he had absolutely no problems with. So it actually ended up going very smoothly, but we kind of wanted to maintain some of those options to either pause or do some microinductions if we had to pause the methadone or whatever, but we managed to get him off it smoothly.
That's great. That's really interesting. So your dose of buprenorphine was 1 milligram 22 hours after the 10 of methadone.
Correct.
And then you gave, or after the 15 of methadone, and then you gave 10 of methadone, and then the next day, 23 hours, but you gave 1 of buprenorphine, and then the next day, 23 hours later, after the methadone, you gave you gave 1 of buprenorphine and then 5 of methadone. So, I mean, you're really doing a normal induction except for waiting 23 hours and then giving an extra 2 small doses of methadone on top, but there's a little buprenorphine already in. That's kind of a neat end of the taper.
Yeah, so that's exactly right. Yeah, you got 1 milligram, like you said, after the 15, but right before the 10, after the 10, right before the 5, and then after the 5, we started going up on the buprenorphine.
Comments or questions about that? You're modifying slightly, really this is a real slight modification of a microinduction in a sense.
Right.
And I think that, some of the, how to do this for different combinations of medications and to expedite the taper, there will be a lot of individual variation, but I think that that's going to be, as people get good at this, and then using the adjunctive medications as well, it'll be really useful and important. But if somebody doesn't know what they're doing, it's going to be potentially disastrous. Ingrid, do you have another question?
Yeah, I do have a question. I'm just wondering about is your plan to keep him on the QID dosing for pain control, or are you looking at eventually moving him to once a day dosing for his opiate use disorder?
At this point, he's on BID dosing for some combination of pain control. I mean, this was a couple of months back, and he stayed on the QID kind of in the post-operative setting. He has, some degree of chronic pain from all of this, so we're still dosing it twice a day. He says he gets some benefit from it from pain, but doesn't want to really be bothered to take it more frequently.
Thank you.
Great.
All right, well.
Last case.
Yeah, so it's similar, so it's a variation on a theme, is that we have a young woman came in from an outside hospital, admitted directly to our acute physical rehab hospital after being treated for a tricuspid valve endocarditis. She had septic emboli, strokes, aneurysm coiling. She had all those strokes because she had a PFO that was closed. She had an infected finger that ended up getting amputated. So she's coming in. She's her mental status is appropriate, but she's got all these strokes and then some contractures and a lot of pain. And just as part of her whole treatment, they just started her on 30 of methadone and didn't address any sort of follow-up plan for her. And so she ended up in our lap with kind of a need to make a follow-up plan for her. So I think we kind of went over the approach for a lot of this. Obviously you could just taper her off of it. You could switch her to full agonists. You could just say, well, you got some pain. Let me just put you on, some MS Contin or something instead while we're doing all this. Or obviously the option to do the buprenorphine. So we can move on to the next slide there. So it was, similar. She was getting some Norco for pain at the time. And we did the same thing. We kind of increased our opioid-sparing meds. We immediately kind of dropped her. We had a little bit less time to work with this patient, so we dropped her from 30 to 20 and then tapered by 5 milligrams every 2 days. Or I guess we had about a similar amount of time, but we just chose to go about it this way. And same kind of idea is that we held that morning Norco as we were starting the buprenorphine so she wouldn't get it, and moved on with a bit of a cross taper there, which you can see on the next slide, which very similarly, because she was getting 5 milligrams. She had gotten 10 milligrams, and then, I guess I have this arranged a little wrong, but she got 10 milligrams, then she got 1 milligram of buprenorphine 2 hours before the methadone. Same thing, 22 hours after that, got another milligram of buprenorphine, got her 5 of methadone, then got started on a milligram BID. And she really did kind of progress according to this schedule where we just kind of gradually titrated her up. She got on to 2 milligrams QID, and that was helping with her pain. She was able to participate in her physical therapy and stuff. And then she actually started having fevers again, and got blood cultures and was positive. So despite her antibiotic treatment for her endocarditis, it was still there. So she actually went for a sternotomy and a tricuspid valve replacement. We increased her Suboxone in that setting. After she had been doing good on the 2 QID, we just increased her to 4 QID with some IV buprenorphine and adjunctive meds. And she did well with her surgery and got discharged on 4 QID.
That's great. I have a couple of questions really quickly. When you're doing the 1 milligram of buprenorphine, are you just cutting the 2s in half, or do you have any other formulation that you use as the first?
Just having them cut them in half.
Okay. And then the second, I think for your adjunctive medications, I saw in both cases you have acetaminophen, ibuprofen, tizanidine, and gabapentin. And I'm wondering, what other people think about kind of adjunctive medications and, preferences. I suppose that it would be patient-specific, but I have a cocktail myself. I usually will recommend clonidine and hydroxyzine, and I often try and stay away from the gabapentin because I think it gets left in place in patients, then it just has a lot of baggage with it. Any comments or questions? Why the tizanidine?
Well, I can tell you our approaches. I mean, that both tizanidine and gabapentin, particularly in acute pain scenarios, have been shown to have some opioid sparing effects, and I'm not certain whether is that truly just the opioid potentiation of gabapentin, but at least it's not going to worsen any sort of precipitated withdrawal or anything like that. And I agree that it's my goal to get the patients off the medications. Tizanidine was chosen for these guys because the one guy had his laminectomy, so definitely had some muscle spasm issues, as did our patient with the contractures from her stroke, so some sort of antispasmodic, but we'll use it as well for patients who don't necessarily have a lot of spasm-related pain, but as kind of just an attempt to potentially, potentiate their opioids, and with like that centra alpha agonism of the imidazolines. I mean, like I said, it's been shown to have some opioid-sparing effect, and I think it might be due to its sympatholytic response, decreasing people's kind of sympathetic response to pain. I'm not totally certain, but sometimes we'll add it in.
Well, that's great. Thank you. No, that's useful description. Makes sense. We're almost up for time. We have just maybe another minute or so if anyone has any other questions, or maybe you can run through the.
Yeah, I'll run through my couple of things unless people have questions. Bernie's method is that micro-induction we've talked about a couple of times. We can skip over that. But my couple of studies I thought were interesting is that in these patients who are, maintained on 100 milligrams of methadone, in this study they took 16, 20 patients, and they started giving them increasing doses of buprenorphine until they found a single dose of buprenorphine that would cause them to have precipitated withdrawal. And it was varying actually between 1 and 8 milligrams. And then they took those patients, they washed them out, and they gave them the same dose. So say it was 8 milligrams is what took this 100 milligram of methadone. So it took 8 milligrams to cause precipitated withdrawal. They then took them and they gave them 4 milligrams and another 4 a couple hours later. That's that split buprenorphine group. And they actually found that if you separate the doses by a couple of hours, you get much less precipitated withdrawal. So that's my justification for hitting them with 1 milligram QID when I'm trying to do these kind of precarious inductions, is split it up. They're going to have less withdrawal that way. So there's at least some evidence that even though you're giving them the same dose, that by splitting it, they'll have less withdrawal.
Now, this is a study, a double-blind, placebo-controlled, randomized crossover study where the same patients went from 100 milligrams to 24 hours later, the 0, 2, 4, 8, whatever it was, and it showed that at the lower doses, you could start 2 milligrams of buprenorphine, or these small doses after only 24 hours on 100 milligrams of methadone, and really not have a lot of effects, not have a lot of the bad effects or feel sick, right? That's
yeah, exactly.
So, that's what, and we've talked about this paper in the past over the years at this conference, and, I think, it's interesting. Smaller doses, split, like you said, after methadone, even after higher doses, patients can tolerate them if it's done right. So, when you get down to 40, it's really not that challenging to do an induction 24 hours later after, I think the way you're doing sounds like, patients had really minimal side effects and worked really well, but in a crunch, you could shorten the time. Any other
I agree.
questions?
We could have been much more aggressive with those patients. What we did worked well, but we totally could have been more aggressive. And then the one other study I wanted to talk about was just this one. These patients were maintained on much less methadone. I think it was 30 or 40 milligrams. But you see that the amount of withdrawal that they had from anywhere from half a milligram all the way up to 8. If the methadone or if the buprenorphine was given 2 hours before their methadone, they had maybe a little bit of withdrawal, but it paled in comparison to say Narcan precipitated withdrawal. So if you're doing this crossover taper, you want to make sure to be giving the buprenorphine before the methadone, because I think on the next slide I think I have here is that they did a similar study, whereas they gave, this is the same kind of thing, where the buprenorphine was given after the methadone, and the buprenorphine, that B on the right side there, the withdrawal was similar to what you get with Narcan. So if you give it 22 hours, even though methadone has a longer half-life than that, if you give buprenorphine 22 hours after during your cross taper, you'll have better success than if you do it, right after they get their methadone dose. So those are my couple of take-homes on these kind of cross tapers here. Is I always try and split the dose as little as possible, and I try and give it before they get their other opioids.
That's great. Those are really useful references. Thank you for putting that together. We are at our time. This is a little bit atypical. We were the fourth Friday due to the holiday, Passover. We're going back to the third Friday at the same time, 1:15 Eastern in May. If anyone has cases, please let me know and send them. It'd be great to have some other presenters. I want to thank Mike from Buffalo for presenting. That was a great case, and thank you, Henry, for your cases as well. Everyone have a good weekend, and thanks for joining.
Thanks, Tim.